This is Donald Fry presenting uh, a discussion on surgical risk of transmissible disease to accompany the textbook chapter in Yeoman and Wynn's textbook of neurosurgery. The objectives of this chapter will be to provide a historical vignette on why concerns about occupational bloodborne infection and surgery have had a major role over the last several decades. I will then detail the data that documents the risks of occupational transmission of the specific diseases that we're going to talk about. I will provide recommended strategies to avoid blood exposure in the performance of operations. We will define then the appropriate responses when blood exposure occurs, and we'll conclude with the discussion about future consideration of potentially other pathogens that may be of concern for occupational transmission. From a historical perspective, surgeons have been known to be at risk for contracting hepatitis B since the early 1950s. With the definition of specific serological techniques, it became apparent that the frequency of hepatitis B infection was far greater than was initially believed. And that's in part because only about 25% of infections with hepatitis B have a clinical syndrome associated with that acute infection. There was a certain amount of ambivalence that existed about the entire issue because surgeons really did not appreciate the frequency with which hepatitis B actually was occurring in the workplace. With the identification of the human immunodeficiency virus in the 1980s, the issue of bloodborne infection became a major clinical issue. And as you can see from the cartoon that I've copied from USA Today, in the mid-1990s, surgeons were concerned about acquiring HIV infection from infected patients, and patient advocacy groups were concerned about whether infected surgeons represented a risk to patients. Exhaustive epidemiological data was identified by the Centers for Disease Control, and it was identified that only about 58 cases of occupational healthcare HIV infection actually occurred from the beginning of the epidemic. There were 150 possible cases of transmission that were identified among physicians and other healthcare personnel that had blood exposure and had no non-occupational reasons to identify potential infection. So as you can see from the beginning of the HIV epidemic, the number of healthcare professionals with documented or possible HIV infection was actually relatively small. The frequency of infection occurring following percutaneous exposure to patients known to have hepatitis B, hepatitis C, or HIV disease are illustrated here. These are principally with hollow needle injuries that have occurred. And as you can see, hepatitis B has a very high rate of transmission, but only 5% of people that have acute hepatitis B infection actually develop the chronic disease that is present really for the remainder of their life. For hepatitis C, the transmission rate is only about 1 in 50 events, but it has the ominous consequence that those that get infected have a 60 to 80% risk of developing chronic disease. The percutaneous injury data on HIV shows a 0.3% seroconversion rate, but those that acquire occupational infection, like others with HIV disease, can be expected at the present time to have the disease for the remainder of their life. So the prevention and management of exposure has these elements. I think it's important that surgeons should be aware of what their serologic status is. An important point to emphasize in this discussion is that effective treatments for hepatitis and B and hepatitis C are available at the present time, and HIV infection, while not curable, is certainly put into a state of long-term remission with effective HIV treatment. So one must know your serologic status so that when an exposure event occurs, one is informed about their current status before any transmission is potentially documented. I think it's important that every surgeon, every person that is involved with healthcare and patient contact should be vaccinated for hepatitis B, and we will talk more about that later in this presentation. Operations should always employ personal protective barriers, and surgeons should optimize protective barriers to minimize any potential of blood contamination or exposure in the operating room. High-risk technical methods in the operating room should be avoided, and we'll talk specifically about those. And if an exposure event occurs, as is commonly the case for busy surgeons, then a prompt response to exposure events should be undertaken. The hepatitis B vaccine is very important, and it has been documented now over several decades to be quite safe. The traditional and the new vaccines are yeast-derived. They are not attenuated viruses from infected patients. The traditional vaccine is given in 3 doses over a 4 to 6 month period of time and has been repeatedly shown to have a 90 to 95% response rate among those that are vaccinated. It is critically important that once vaccination has been completed, that the individual at 1 to 2 months following completion of the process has their serologic status documented that they are indeed a responder. There is a new hepatitis B vaccine that has a novel adjuvant. It has resulted in 2 doses instead of the traditional 3 doses, resulting in effective response with antibodies. It's been reported up to a 100% responsiveness. But again, the same rules apply, that the response to the vaccine should be documented 1 to 2 months following completion of the process. Prevention of exposure events in the operating room begins with personal protective barriers. Eye shields should be worn Double gloving, I believe, should be done in all procedures, all major surgical procedures. Sleeve reinforcements will provide extra protection against blood penetration through the gown. Aprons have been worn in particularly high-risk kinds of operations where large amounts of blood loss are anticipated, and for many trauma cases, trauma boots are commonly worn to avoid blood exposure of the feet. Technical modifications include taking extra care with using wire sutures. Traction injuries with tying wire sutures can be a real problem, resulting in digital laceration, and it is desirable to avoid cuts and lacerations not only for the current operation, but having those injuries for future procedures can be highly problematic. Avoid blind suturing techniques where the tip of the needle is being palpated. In cases where there is a frequent exchange of loaded needle holders, a Mayo weigh station can be an important way of avoiding injuries with the passage of loaded needle holders back and forth between the scrub technician and the surgeon. Remove swedge needles before tying the suture. I think there's some considerable interest in blunt needle technology, and it has been shown to reduce percutaneous injury, but probably more important than anything is having an awareness of all sharp instruments and sharp surfaces that may be present during the procedure and avoid having injury from those sources. Double gloving has been controversial over time. Here is a study that we did showing that double gloving really does not adversely affect the manual dexterity of the surgeon. This study was done with 53 surgical residents and with surgeons in practice. The scattergram here plots out the manual dexterity performance of the surgeons with bare hands versus single glove versus double gloves. As you can see, the regression lines are identical relative to whether single or double gloves were worn compared to bare hands. It is interesting to see the negative trend over time, reflecting the fact that aging does have an effect upon manual dexterity. There should be a generic response to blood contamination or percutaneous injury. Rescrubbing is ideal, but is usually impractical in a big surgical case, so removing the glove, rinsing the area with povidone iodine or isopropyl alcohol or chlorhexidine is generally recommended. There really is not evidence to show that that makes any difference, but these are virucidal antiseptics, and it makes good sense to irrigate the injury immediately. The baseline serology of the surgeon is obtained. The serologic status of the patient is determined if possible, and this may require getting permission from patients to be tested. If the patients know that the surgeon is being tested as well, it generally results in patients giving consent for the testing process. When appropriate, a post-exposure prophylaxis protocol is completed, and that should be dictated largely by the magnitude of the injury and not because of presumptions that one might have about the patient's infection status. Post-exposure prophylaxis is detailed in the written textbook chapter, and here is the algorithm that I will go through on a step-by-step basis for prophylaxis following a hepatitis B exposure event in the operating room. Basic questions need to be answered in terms of post-exposure prophylaxis. If the patient, or if the surgeon has had prior HBV infection, then nothing is going to be necessary. But if you've not had HBV infection and you're a naive host, then the question is, have you had HBV vaccination? If that is not true, then one should receive a hepatitis B immunoglobulin dose, and the hepatitis B vaccination process is initiated. And once it's completed, one must validate that an appropriate response has been achieved to the vaccination process. If you have had previous vaccination, and you have antibody positive, or if you've had hepatitis B infection previously and you are known to have an antibody response from that presumed clinical infection, then you are protected against any future risk of acquiring hepatitis B, and no further treatment is necessary. If the surgeon has an unknown vaccination response, then a challenge dose of the vaccine is given to elicit whether there is an antibody response or not. If there is a positive antibody response, then no further vaccination or treatment is necessary. If negative, then the individual should be treated as a non-vaccinated person, meaning that they get a dose of hepatitis B immunoglobulin and full vaccination is started. If the surgeon is a known non-responder, then 2 doses of the HBV immunoglobulin are given 1 month apart. And in the current environment, with new vaccines having been developed, the non-responder should consider having a revaccination with one of the newer adjuvant hepatitis B vaccines. HCV exposure is totally handled differently than HBV exposure. Following an HCV exposure or a high-risk percutaneous injury where HCV is suspected, then the surgeon should be monitored for 6 months to establish whether seroconversion has happened. If the surgeon seroconverts, then treatment is initiated with direct-acting antiviral therapy. Immediate prophylaxis after a percutaneous event with the direct-acting antiviral therapy is not employed, since this would result in 49 treatment courses out of 50 exposed individuals that would be of no value. Remember, the conversion rate following percutaneous injury from hepatitis C is about 2%. So the current recommendation is that one be monitored after the event and then be treated with the direct-acting and highly effective antiviral treatment for hepatitis C infection. There is currently no vaccine available for hepatitis C, but it is the focus of considerable research. HIV post-exposure for prophylaxis should be initiated within 72 hours of an exposure event. This antiviral treatment would consist of 3 drugs given from 2 separate classes of current HIV drug therapy. There is usually a local protocol established within each hospital for the management of such exposure events. The post-exposure prophylaxis treatment should be continued for 28 days. It is not considered 100% effective, and the exposed surgeon should be monitored for seroconversion following completion of the prophylaxis protocol. With all of this having been said, I think it's fair to say that the full spectrum of bloodborne and vector-carried viruses remain undefined. It is likely that there will be additional hepatitis viruses to be characterized. And it should be understood that in the era of intercontinental transportation, that someone with a bloodborne infection from a remote location may actually appear for surgical care in your institution. So the upshot of it is avoiding blood exposure is critically important. For neurosurgeons in particular, prion disease has been iatrogenically transmitted to naive patients from contaminated surgical instruments and from biological products of neurological origin in patients that have had Creutzfeldt-Jakob disease. This is a most interesting disease that's associated with protein transmission rather than a true infectious agent as we've traditionally viewed them, but is a source of real concern, especially in neurosurgical cases that are being done where the patient's full disease may not be characterized at the time of the operation. So in summary, neurosurgeons should understand hepatitis B, hepatitis C, and HIV infections as occupational risks from blood exposure in the operating room. Personal protective barriers and standardized surgical techniques should be employed to avoid blood exposure. All surgeons should have received the hepatitis B vaccine, and they should be well aware of their response status so that alternative post-exposure prophylaxis methods can be employed. Standardized post-exposure strategy should be employed for all major percutaneous exposure events. Effective antiviral therapy is now available for both prevention and treatment of these occupational infections, and it requires that surgeons know what their current status is. Finally, unknown risk from bloodborne contamination exists. I think it's important that you avoid blood exposure. I've always liked to refer to blood as a toxic substance that has unknown consequences when there is exposure, and using standardized methods to avoid blood exposure is certainly